Live.
We are, yes.
All right. Hello, everyone. Good evening. Thank you to each and every one of you for being here with us with the online conference today. We are very pleased to be able to welcome those of you that have been with us for a long time now, and as well as those who are new, who joined newly to the group. With great pleasure, I get to introduce the first speaker of the Six Excellence in Endodontics online conference, Dr. Abu Ubaida Al-Iraqi. Dr. Abu Ubaida obtained his bachelor's degree in dentistry from Baghdad University in 2004. Following the four-year program, he was granted a higher dental diploma in prosthodontics from Cairo University, Egypt in 2009. Dr. Abu Ubaida took a part in a training program in endodontics. Since then, he has been working in his private clinic that is limited to endodontics and aesthetic dentistry. Dr. Abu Ubaida has remarkably lectured in national conferences, and he is extensively running and supervising courses in basic and advanced endodontics. Dr. Abu Ubaida has a great passion toward education and sharing his knowledge, not only through on-site courses and conferences, but also through social media platforms. He is very active in publishing clinical cases that reflect his excellent clinical skills. His cases won Post of the Week and Post of the Month on many occasions in Excellence in Endodontics Facebook group. And he was the winner of the Post of the Year in 2021. With such a great biography, please let me welcome Dr. Abu Ubaida, and let's have a great time having him as a lecturer today.
Thank you so much, Dr. Mustafa Kabbani. Thank you so much for presenting me. I would like to thank all the attendees, all of my colleagues. But before this, let me share the platinum, gold, and silver sponsor of this great conference.
Yeah.
Let me share the screen. Okay. Wait a second. Okay, here we go. Excuse me. Okay. Did I miss something?
You showed the video, but now it's stopped. Can you
let me okay.
Yeah, reshare the screen?
I have to do it again. Okay. There we go.
Yeah.
Okay, thank you so much for the platinum sponsor, Zark Files, Zark Company. And I would like to thank also Dinjoy Company for being the golden sponsor of this conference.
Dinjoy Dental Company Limited is a professional manufacturer in China dedicated to R&D, production and sales, a full line of endodontic equipment in dental field since 2004. Our company has complete production and examination equipment and perfect quality management system ISO 13485. We are one of few manufacturers in global dental field to produce full set of root canal therapy. Our advantages are specialty of products, immediate delivery, and prompt after, consistent to the principle of quality first, customer supremacy. We cooperate with customers at home and abroad.
Welcome. Okay, thank you so much, Dinjoy Company, for being our golden sponsor of this 6th online conference. Now, I would like to thank also our silver sponsor, if I'm not wrong. Yes, it is our silver sponsor, Coxo Company, and bronze sponsor, Ramo Company and Atif Company. Now, let's get into our topic. I call it more or less apical control and apical gauging. I would like to present myself as I'm a silver member in the group Excellence in Endodontics since about 6 months ago. I would like to thank Prof. Ahmed Madrati for inviting me to be a member on such a great group. Now, before we start, I want to share you this study which is done in 2014, which is a promotion of endodontic lesion in rats by novel extraradicular biofilm model using obturation material. This study was done in June 2014. As you can see in the picture, there was an extruded gadaperca over the apex of rats. As you can see, the biofilm on the extruded gadaperca. Even the gadaperca is sterile, and the whole condition was done in a sterile condition, but still the gadaperca, the bacteria grow on the surface of the gadaperca. The conclusion of that study was no extraradicular biofilm formed without projecting gadaperca points even after 2 weeks of pulp exposure. Second point, or second conclusion, gadaperca point projecting from the apical foramen may serve as a scaffold for extraradicular biofilm formation in clinical practice. And third conclusion, a loose root canal filling and overfilling greatly increase the possibility of extraradicular biofilm formation in clinical practice. What does that mean? So even we have sterile condition, if no gadaperca extruded beyond the apex, we will not have the bacteria will grow on the surface of the gadaperca. And if we also work in sterile condition and the gadaperca projected from the apex of the gadaperca, there will be a scaffold of extraradicular biofilm. And in case of loose root canal filling or overfilling, this will greatly increase the possibility of extraradicular biofilm formation in clinical practice. So if you have overfilling, try to have good apical seal. Even you have overfilling to minimize the growth of the bacteria on the surface of the gadaperca. Remember, this is talking about gadaperca. If you are talking about the sealer, remember all sealers are bioactive. Bioactive is not a good word. It has two meanings. When we say bioactive, it means either it has a biological response, and this response could be good or bad. Let me show you this case done by me 3 or 2 years ago. As you can see, this was upper 6. It was symptomatic apical periodontitis with irreversible pulpitis. And I did, at that time, what I thought, I did a great job. I used, in this case, resorbable sealer. As you can see, after a few months, you can see that the sealer material was resorbed, and even the resorption happened inside the canal. So my sealer buff, which is in huge amount, was masking the mistakes I did in my obturation. As you can see in the mesial root, as you can see after I'm zooming in, you can see I have under obturation or underfilling, but the sealer masked the mistake I did. So this is one of the reasons why we should avoid too much sealer buff. Another case, this is our central symptomatic apical periodontitis with apical lesion. As you can see, I did nice obturation, and I thought that I have lateral canal, nice sealer buff. Again, I used a resorbable sealer. And after a few months, as you can see, I have overfilling, not underfilling. So the sealer buff was masking my mistake.
Yeah.
Now, how to avoid this? Let's start from early beginning. How to avoid overfilling or underfilling, how to avoid over-sealer extrusion from the canal. First of all, let's remember that maximum file size allowed to violate the apical foramen is 10 only, 0.5 millimeter or 1 millimeter. And this is very important. So usually, if you are willing to do patency, remember the maximum size allowed to do so is by file size 10 or smaller, not larger, and do not over go beyond the apex by more than half a meter or 1 millimeter.
And it's performed by gently pushing small, highly
With the
flexible
courtesy of
particles into the
Cliff
radiographic
Ruddle
tunnels. To ensure
video,
paint
you can
seal,
see the
ground tip
patency.
is intentionally inserted minutely through the foramen
As
to
you can
discourage
see,
the accumulation
the
of
K file
grain.
is crossing
Importantly,
beyond the
before
apex
being
only
installed,
half or
flexible
1 millimeter.
ground to the radiographic terminus.
Okay, here you can see in the distal root, I have 10 K file, which is crossed the apex, but more than 3 millimeters. In this way, so the apical foramen size will be larger than 10, could be like 16. As you know, K file 10 has taper 2. So if I'm going 3 millimeter over, that's mean the apical foramen size will be 16.
Yeah.
As you can see, after obturation, I have a lot of sealer went beyond the apex. Also, the Gatipirca was almost fit, but the sealer went too much beyond the apex. And was the reason was beyond this, that the K file 10 across the apex more than 3 millimeter, not half millimeter or 1 millimeter. If you can see, the sealer buff is almost above the inferior alveolar canal. This could have serious consequences if I would violate the inferior alveolar canal, and the sealer might rest on the inferior alveolar nerve. And this would be very harmful if I'm using a sealer with formaldehyde. Second point, it's better to take your measurement with metal ruler, not with the plastic one. As the plastic one, as you can see, it may deform with the sterilization. So you may not have real measurement. So I'm not advising you to use a plastic ruler unless you are doing the instrumentation and the obturation at the same visit. Third point, reference point should be stable and repeatable. This is very important. If you are changing the reference point after taking working length, and the reference point will go to another place when you are doing shaping of the canal, you will no way have either under instrumentation or over instrumentation. As you can, this is what I like to see when I'm doing reading, when I'm taking apex locator reading or doing shaping. I like to see the stopper is resting on the stable and repeatable reference point. This is another example. This is another example. I don't like this example because, as you see, the stopper will always rest on a slope. So this might change. So please try to have stable and repeatable reference point. Some clinician reduce the cusp to have a stable reference point. I'm not advocating this. I want the tooth to stay as it, not under occlusion, unless the tooth is weak and I'm going to crown the tooth. Fourth point, apex locator. Apex locator should have trusted, accurate, and stable reading, otherwise change it. Apex locator is not a toy. Apex locator is not something to maneuver it. Apex locator should be very trusted, otherwise it may screw up the whole procedure. So you can use whatever you want in your clinic, but make sure it is a trusted and give you stable reading. Fifth point, it is preferred to confirm apex locator reading while file in position with radiographs. So if you are taking working with reading with apex locator, it is preferable to confirm this with the radiograph. But remember, the final word is for the apex locator, not for radiograph, unless you have a problem with your apex locator. All of us know about the anatomical apex and radiographic apex. As you can see, I'm confirming my reading with the X-ray. Usually, I'm not doing this in all cases, but it is preferable to do it in all cases. But if you are in a hurry, then I telling you to confirm the reading when you have an open apex, because all of know most of apex locators does not give you accurate reading when you have open apex. One more thing, when you have long roots, long canals like 23 and more, usually with long canals, the apex locator does not give you accurate reading. And if you are seeing or watching that the apex locator scale is running up and down, and you cannot get a stable reading, this way you may need to confirm your reading. 6 point, take new working length reading after initial reading, especially in curved canals. Well, clinician should not depend only one working length. As we know, in curved canal, after introducing first rotary file into the full working length, the canal will little bit straighten. So after straightening the canal, the working length will be little bit short. So you need to take another apex locator, another working length reading, especially in curved canal. I can show you this case. This is our first premolar with curved canal measure root. My first reading was 23. After introducing the first rotary file into the full working length, my working length gets shorter, 22. So this is very important. When you have a curved canal, please try to
multiple reading.
Yes, multiple reading. And this is post-obturation. 7th point, watch file every time you pull it out from the canal. File unwinding. This is especially true when you are dealing with the heat-treated file. Before, when we used to use austenite file, we don't have the signs of fatigue. Usually the file break up and you don't know that it is already stressed. But with the heat-treated file, one can know that the file is already stressed and time for throwing it. So when the file has unwinding phenomena, when the floats of the file are opened, the file will get longer. So if you have, for example, a working length reading 20, and after unwinding, the file will get longer, maybe 21. So you need to watch this. And this is a good sign to throwing the file. I remember I asked Prof. Yushi, when he came to Baghdad, when do you throw file? He says, well, I throw file in only 2 cases. First case is when the file breaks inside the canal. And the second case, when, we are not Yushi. We are not.
That's
Yushi.
easy for him to retrieve any file.
He can try anything. Okay. So we are not Yushi. So please don't take his point seriously. Second point, when you see unwinding, once you see unwinding, then this is a sign of time to throw the file. By the way, nowadays files are getting cheaper and cheaper. So, and I think one day, and we are very close to this day, our rotary file will be disposable only for one use. And we will get rid of many problems, especially file separation. 8th point, once file reach full working length, okay, 2 to 3 touches is enough. What does that mean? When I introduce the rotary file into the full working length, I don't let the file to spin or to keep rotating inside the root canal for a long time. 2 to 3 touches is more than enough. We call it kiss the apex. Please do not over enlarge the apical foramen. 2 to 3 touches is more than enough. As you can see in this video. 1, 2, 3. That's it. Please don't let the file to keep rotating inside the apical part of the canal.
Doctor, I have one question here. Even if we are brushing, we are using brushing motion for the canal?
Even if you are using whatever.
We don't have to go to the full working length.
2 to 3 is enough. What the file will do more than 2 to 3? What are you waiting for? What are you waiting for? That's more than enough. Okay. And 9 point, maintain continuous tapering form. We all remember JV Black, called JV or JV Black rules for amalgam. We have wide cavity apically and diverge design apically and converge design occlusally to have retention form or resistance form. Same thing will be applied when you are doing shaping for the root canal system. Always remember that the root canal system is already a taper form. So try to maintain this taperness. So the coronal part of the canal should be wide and it get narrower when you proceed and progress apically. In this way, you will have resistance form or retention form, and you will prevent the catapulca from extruding beyond the apex while you are compacting with the continuous wave of compaction or worn vertical compaction. As you can see, how the apical foramen are, the apical shaping are getting narrower when we progressing apically. So wider coronally, getting narrower in the middle part, and getting very narrow at the apical part. And this way, you can control the guttapierke apically. If you can see this this X-ray done by my colleague, the apical part is almost similar to the coronal part. So there will be no retention form, no resistance form, and of course, with simple compaction, the guttapierke will go beyond the apex. Although I know this dentist, he done this case with the single cone technique, not continuous wave of compaction, neither with the worn vertical compaction. And still, the guttapierke went beyond the apex. Simply why? The apical, he already shaped the apical foramen, apical part of the canal too much, and he did not maintain the continuous tapering form and the original anatomy of the canal. So with the simple obturation, the guttapierke went beyond the apex. 10th point, be careful when activate with the ultrasonic not to straighten the canal. Well, if you go to literature, you will read that the best activating device is ultrasonic, not sonic, not subsonic. Although, if you are asking Professor J. Cliff Riddle, he recommending endoactivator, which is, I think, subsonic activation. If you ask Professor Alfredo from Italy, he will tell you that ultrasonic is best. For me, I prefer ultrasonic, but remember, don't let did I miss something? Do you hear me, Dr. Mustafa?
Yes, everything is
yes,
okay.
Okay.
Yeah.
Be careful when activate with ultrasonic. For me, when I activate the irrigant inside the root canal, I always recommend and use ultrasonic. But I sometimes also use sonic or subsonic. But ultrasonic is the best. But remember, don't let the ultrasonic tip to get to the full working depth. As you know, there is strong vibration, and this is may change the apical geometry of the canal. So you may have
alter the shape.
Yes, shape, and later on the apical the part of the canal will be enlarged. So you may be not able to control the obturation apically. 10th point, do apical gauging after shaping, especially in open apex, apical lesion and apical violation. Well, before I had many cases, I do everything right, everything, but I also have overfilling or over obturation, and could not know why until I attend one of the lecture for the great professor Dr. Marco from Italy, and he was talking about the apical gauging. Simple apical gauging, we are measuring the diameter and the taperness of the apical part of the canal, especially the apical foramen. Do we need to do apical gauging for all cases? In fact, I'm not doing it for all cases, but it is recommended to do for all cases. But if you are in a hurry, please don't jump this point. If you have an open apex, if you have apical lesion, and you thought that the rotary file or even the K file went beyond the apex during shaping, please do apical gauging. And I will talk about this when I finish all these tips. As you can see in these X-rays, this is our first molar. You can see the guttapierke reaching the full working length, and I don't have a problem with it. Everything looks nice, but as you can see, this is not fully formed root. Still, I don't have complete formation. So in this case, I had to do apical gauging, but I did not do it. As you can see the result, I have overfilling distally. Another case, this I have apical lesion, and I did not do apical gauging. As you can see, I had overfilling. Okay. Number 12, guttapierke cones of same size are not equal in apical diameter. Please remember this. When you are buying guttapierke, when the company telling you this is guttapierke 25 taper 4, okay, in fact, it is not 25 taper 4. It could be, yes, 25 taper 4. It could be 24 taper 4. it could be 23 taper 4, or even it could be 26 taper 4 or 27 taper 4. So even the company telling you this is 25, in fact, it is not 25. So how to overcome this problem? Look at this Gatipeka. This is from Diadent. You can see this is all was withdrawn from the same slot, the same box of Gatipeka. All this is supposed to be 30 taper 4. As you can see, they are not the same. And this is from Elephant, the great company from China. Same. And this is from even Dian Supply, the greatest company. Okay, you can see that the Gatipeka is not matching. So how to overcome this? You need to have a trusted Gatipeka gauge. I use this simply when I need Gatipeka 25. I place a Gatipeka 20 in a 25 hole and I cut it. Then I cut a 25. If I need 30, then I put Gatipeka 20 or 25 in a 30 hole and I cut it, and I will get a precise 30. Please look at this video. I was needing Gatipeka 35, so I brought Gatipeka 30 and I put it in the 35 hole. And I cut it and I get a precise 35 Gatipeka. So whenever you need a Gatipeka, please take a smaller size and put it in the larger hole. You will get a precise size. So if you are needing 25, please use 20. If you are needing 30, please use 20 or 25 and put inside the 30 and cut.
So you place a smaller size, doctor?
Smaller size. Yeah, smaller size. Because well, if I'm needing Gatipeka 25, okay, if I bring Gatipeka 20 could be 19, could be 18, could be 20, could be 21, 22, but it will not reach for any reason 25.
Yeah.
And same will be applied to 25 or 30. You got my point?
Yeah, I got it.
Okay. Check the expired date and elasticity of Gatipeka cone before confit. We know before obturation, we introduce the Gatipeka into the full working length and taking X-rays. Sometimes if you have body quality or expire Gatipeka, when you are introducing the Gatipeka, after you confirm the working length and when you withdraw the Gatipeka, if it is body quality or expired date, the Gatipeka will cut beyond the apex or inside the canal. So this will be a problem. Look at this case. This case done by another colleague. As you can see, what I think, what he did during either during obturation or during, I think this is during confit. He tried the Gatipeka cone and he introduced inside the canal. And after withdrawing the Gatipeka was, it was already over. So when he withdrew the Gatipeka was cut outside the apex. And this case was done by me. This is upper canine. I introduced the Gatipeka. It was over. So I withdraw the Gatipeka. As you can see, I think it was bad saving or wrong place saving. The temperature was over. As you know, in Iraq, the temperature sometimes exceeds 50.
Yeah.
So
storage is important.
Yes, the storage is important. The problem, it is advisable to keep the Gatipeka inside the refrigerator in the summer. But the problem is we have a problem with electricity in Iraq. So we may have electrical shock or something inside the clinic and may scrub everything. So when we go outside the clinic, we shut down the electricity. We don't get anything. You don't know what happened. Many problems happened before. So when I withdraw this Gatipeka, it was cut beyond the apex. Now I did obturation, but thanks God, everything went fine. Some dentists used XP shaper and introduce it outside the apex, and it may catch the Gatipeka and bring it. The problem with this, the XP shaper may over enlarge the apical foramen. What I heard from Professor Yushi, he's letting very strange by the way, he's letting the chloroform to go beyond the apex, and then he using the XP shaper to dissolve and smash the Gatipeka.
Yeah. But he is activating the Chloroform.
Yes, and letting the chloroform to go beyond the apex. I don't know how to use this. This is
This is a strange
as the
topic. Other than
yes, this is cytotoxic material. He says it will evaporate and the body will accept it and adapt to it, and nothing will happen.
Yeah.
But this is Professor Yushi.
Yeah.
He's not.
This is
he's
a
not-
second strange topic beside the sodium
Okay,
hypochlorite
but-
with the hydration.
Okay, you can ask him. Okay, okay. And this is another case. As you can see, while I'm trying the gataperca, it was cut outside the apex, as you can see. In such case, you cannot do nothing. You do nothing.
Observe
just
only, right?
you just obturate and confirm apical seal and follow up. If you have anything, you can go for surgery. Okay, 14th point, always try gataperca cone with wet root canal and pulp chamber. Before obturation, when we are trying the gataperca cone and to confirm the working length and everything, okay, we should not try gataperca with dry canal. It should be with wet canal. And this wetness should be done with hypochlorite. It will act as a lubricant, just like you are using sealer. If you are trying gataperca cone in a dry canal, it might not reach full working length. Remember this. Okay, as you can see, I always, when I'm trying the gataperca cone, I try it while the gataperca, the pulp chamber and the root canal is wet with hypochlorite, filled with hypochlorite, as you can see here. Number 15, when you are trying the gataperca cone and take X-ray, okay, please do this with little bit force. As if you are just putting the gataperca cone inside the canal, it might not reach full working length. Remember, during obturation, we will compact the gataperca. So imagine if you are putting a gataperca and it is loose inside the root canal, and during obturation, you will force the gataperca apically. If you are not having good tag bag, good apical control, then the gataperca will go beyond the apex. Look at this X-ray. I was putting it, it was 30 taper 4. Look at the mesolingual canal. I put it the gataperca and everything looks nice. But I have a feeling that I did not get that strong tag back. So I withdraw the gataperca and pushed again. As you can see, the mesolingual, the gataperca went beyond the apex.
Yeah.
So when you are introducing gataperca cone, please do it with little bit force. Okay, and this is after obturation. Okay. 16 point, get a true tag bag, not false tag bag. What does that mean? Let me show you this. My advice for my colleague, when you are doing obturation, you can prepare the canal with 0 taper 6 file, but please do not fill the canal with gataperca taper 6. You can do shaping with taper 4 or taper 6, but when you are obturating, you can obturate with taper 2 or taper 4. But please do not obturate with taper 6 unless you are over enlarging your prep. As if you are using taper 6 gataperca, you may get false tag back, and the gataperca might bind coronally or middle part of the canal. And after obturation, once you cut the gataperca and you compact the gataperca, it may go beyond the apex. How do you know you have true tag back or false tag back? Simply, you can look at this. If you are seeing any binding, any indentation inside at the middle part of the canal of the gataperca cone, that's mean you have false tag back. If you have indentation or an serration in the apical part of the gataperca, that's mean you have true tag back. Number 17, after gataperca confit, if you are using or vertical compaction or continuous wave of compaction, you need to cut 0.5 or 1 millimeter of the gataperca cone. As you can see, we are trying the gataperca here. This fit, but I have to cut now 0.5 millimeter. Why? Because after obturation, with the worm technique, the gataperca will molten and will progress apically. Otherwise, you may let the gataperca to go by the action of the thermoplasticity and the molten effect of the gataperca. As you can see here, it is fit, but I have to cut 0.5 millimeter So when I have obturation, I can't control it.
Yeah.
Okay. What tool should I use to cut the catapecta? Scissor or blade? My advice for you is to use sharp blade. The sharp blade will give you sharp cut and not with any extra material of the catapecta cone. Okay.
But doctor, this step will be after using the cutter, that the one that you showed us.
After using the cutter. After using the cutter. Okay. So you have two cuts. Okay. Number 19, use minimum amount of sealer. Please do not overuse. Don't use too much sealer when you are obturation. It is only small layer. Although I've seen Professor Ruddle using too much sealer, but I'm not advocating this. I only use a small layer of sealer. Okay. When you are introducing
Following drying the canal, the pre-fitted master cone is buttered liberally, and the cone is slowly and carefully teased to place to prevent cement from being displaced periapically.
So when you are using a sealer and introducing it with the catapecta cone, please do it with this movement. Don't use push-pull motion. Push-pull motion will act as a piston and will force the sealer to go beyond the apex. So always by this way, or clockwise or counterclockwise. Please do not use push-pull action.
Yeah.
Number 20, when injecting bioceramic sealer, use backfill technique. Never use forcible injection. As you can see, I'm pushing the plunger of the syringe and withdrawing my hand coronally to avoid extrusion of the sealer. If you are using force while you are injecting bioceramic sealer, you will have this appearance. By the way, this case done by me, and this gave me a great lesson. I would never ever use force while I'm injecting bioceramic sealer into the root canal.
Is this a single cone technique?
No, this was modified hole technique.
Modified
hole technique. Okay. Number 22, use a proper size of endoplugger for each part of the canal. Okay. So you need at least to have 3 pluggers. One for the coronal part, one for the middle part, and one for the apical part. Okay. And remember, when you are using condenser, the condenser should touch only the catapecta, not the walls, the internal wall. Okay. Number 23, when compacting a departure point with a plugger, do it smoothly and gently. Never use force. Never use force. As you can see here, in this case, I was using force, too much force while injecting the catapecta. Look what happened. I had this appearance after I did obturation. So I wanted to force the catapecta little bit apically. So I used fine plugger and I started to force the plugger more apically. Look what happened. The catapecta went beyond the apex, and this was a mistake. Okay, 24. Please do not over enlarge the apical part of the canal more than 40. Any file go to the apical foramen, okay, it will increase the surface area of sealing by this equation. Now, time to talk about the apical gauging. What's apical gauging? As I told you, apical gauging, it is a way to measure the diameter and the taper of the apical foramen. Look at this case. As I told you, it is obligatory to do apical gauging in cases of open apex, in cases of apical resorption, apical lesion, and in case of apical violation. When I have an apical lesion, remember, the lesion will not eat only the bone. The lesion will eat also the cementum and the root. So the apical foramen will be large. So even you are preparing your canal, for example, for 30 taper 4 or 35 taper 4 or 40 taper 4, the apical foramen may be already larger than this size, especially when you have apical lesion. So I remember this case I had, it was my preparation for the parietal canal was 30 taper 6. And when I introduced catapecta 30 taper 4, as you can see, it was already over. So I cut the gatiperca, and I almost have 1 millimeter. As you can see, 1 millimeter or a half millimeter shorter than the apical foramen. But even after obturation, I also had overfilling or over obturation, as you can see here. Okay, this is after the follow-up. Another case, I have apical lesion. So remember, the apical foramen may be already enlarged by the means of the resorption process. As you can see, I'm trying the cones, but even so, the central incisor went beyond the apex. I felt so sad for this case, but it gave me a lot, and I learned a lot from this case. So whenever I have apical lesion or open apex or apical violation, I always do apical gauging. And again, as I told you, gatipercha are not the same size, even they came from the same box, from same slot. Okay, now how to do apical gauging? Simply, to do apical gauging, you can use a stainless steel file, K file, but my advice for you is to use NiTi K file. Why NiTi, not stainless steel? Because the cutting ability of the NiTi K file is less than the stainless steel file. One more thing, when you have curved canal, the NiTi K file will follow the curve, which is not the case in case of using stainless steel K file. Remember, when we say 20 taper 2 or 20 taper 4 or 20 taper 6, they have common thing at the apical at the tip of the file. They have the same size, common size, same size at the tip of the file. So K file 20, rotary file 20, rotary file 26, 24 or 26, they have the same size at the tip of the file. So if I'm finishing my shaping with 20 taper 4 or 20 taper 6, I can do apical gauging with 20 taper 2, because at the tip they are the same.
Yeah.
Okay, let me show you this file. What I do at the apical gauging, let's assume I finished my shaping with 35 taper 4 rotary file. And I want to confirm the apical measurement of my preparation. What I do, I use K file 35 taper 2, and I put it to the full working length, to my work length. Let's assume it is 20. I will introduce the file, then I will tapping it simply by my finger, simply. If the K file did not go beyond the apex, then my apical preparation is really 30. If my K file went beyond the apex, then my apical foramen is larger than 35. If it did not reach full working length, that means that my apical preparation is not 35 and is less than 35.
Yes.
Let's see this video. This is my last shaping file, 45 taper 4. I usually don't go for these sizes, but for some reason I went to the 45 taper 4. Calculation. So my working length was 18. So I brought stainless nickel titanium K file to the working length 18. As you can see, I'm doing tapping. So the file did not go beyond the apex. When I take reading again, it is still 18.
Yeah.
Okay. To confirm this, I bring a Hyperca 40 and I put it in hole 45. As I said, smaller sizes. I cut it. Now I have 45. As you can see, okay, again, I'm tapping it. Okay. I can see 18.
Yeah.
By the way, I should grasp the Gatiperca with the tweezer. I've tried to use it many times, but I didn't like it. So I grasped it with my finger. But this is not right thing.
Do you do this all the time?
Yes, all the time. Okay. So now I filled the canal with the hypochlorite. As you can see, I confirm it with the X-ray. I can confirm it also with the paper point. As I told you, it was 45. This is paper point 40. So it went beyond the apex. And this is 45. You can see little bit of blood. Let's try another one. Okay, as you can see, no blood, and everything looks nice. Now I'm cutting 1 millimeter, half millimeter, or 1 millimeter. As you can see, I'm under half millimeter or 1 millimeter.
Yeah.
Okay, I think I'm finished. Okay.
Lecture. So it was a very amazing lecture. I'm very honored to be the moderator in your webinar. I'm very happy to be with you. So let's go to the questions. I have a lot of questions. Let me start asking, but I have a question myself in the beginning.
Okay.
So when do you do the paper point test? Do you rinse the canal after doing the paper point test, especially when you are seeing blood, for example?
It depends on amount of the blood. If it's too much, no, I will rinse again with cold normal saline.
Yeah.
If I cannot stop the bleeding, then I will use the CO2 freeze, the spray. Okay, what do we call it? The CO2 spray. I forget its name. It's called ice Indo.
Ice.
Indo ice. Yeah. I spray it on the paper point and introduce inside the canal to stop the bleeding. Usually, I use paper point for two reasons.
Yeah.
When I want to confirm the reading of the apex locator, I would like to take measurement with the dry canal. But you know, the new generation of the apex locator, you can use it even with wet canal. But if you to get real reading, it is better to dry the canal. Okay, and after confit and before obturation, I have to dry the canal. I will not let the canal to stay wet.
So basically, you do your paper point test, and then you obturate directly.
Yes. Yeah. This is
all right.
Well, I call get a paper point is my last weapon.
All right.
My last weapon, and
I believe it's
underestimated. Paper point is a very diagnostic tool, very important. Sometimes you see a blood on the side of the paper point while the whole procedure went smooth. Sometimes you may ask yourself, why I have a blooding on the lateral border of the paper point? Did I do perforation? No, it is not perforation. Not necessarily perforation. Maybe lateral canal. So paper point give you many answers. For example, if you have still infection and you are still seeing the paper point still wet at the apical part, you are not ready for obturation. You need to postpone the treatment, place intracanal medicament like calcium hydroxide, and give another appointment. Although, again, Professor Yushi is not advocating this. He says just simply fill the whole canal with MTA and let the MTA to cross beyond the apex, and everything will be right.
Yeah. I once read for Dr. Radel that the paper point test is the most accurate test for.
But I have inquiry and suspicion sometimes. What if the size of the paper point is not accurate?
Yeah. True.
Right.
Well, I usually do. I also cut the paper point.
The same. But remember, if you are cutting with the cutter will get blind if you are cutting it with the cutter, because the paper point is more stiffer than the Gatti-Perka. But I assume that the procedures of making paper point is easier than Gatti-Perka. As you know that the Gatti-Perka, when you are made, they are using it with injection molding technique, so it will be shrink. So that's why you cannot get a true measurement. Okay. I think with the paper point, the procedure is less complicated. So the measurement should be, or the paper point, more accurate than Gatti-Perka.
True. All right, I have a lot of questions. I will start with the first one. One doctor is asking, is there any difference between severely curved canals and straightforward canals regarding the apical control?
Severely curved canal and well, in fact, in case of severely curved canal, we don't have that much problem. As you know, for me with severely curved canal, I don't go beyond a 25 taper 4. This is the maximum size I might reach. So we barely can reach the length, the full working length. And in most of the cases with the severely curved canal, we cannot reach full working length.
Yeah.
So in most of the cases, if you are seeing something beyond the apex, in most cases, this is a sealer. It is not easy to prepare the apical part of the canal. So most of the time that I have poor apical control in straight canal or not severely curved canal.
Another question here, they are asking about your own technique. Do you go for 0-0 reading on apex locator, or do you use a shorter working length?
Well, when I get reading, I go 0-0. I don't. Well, in fact, I have to go over reading, -0, then which is called patency. And afterward, I stop at the 0-0. My preparation will stop also at 0-0. Okay, but when I'm doing obturation, I will cut the Gatti-Perka 0.5 millimeter or 1 millimeter above the apex, and I will let the compaction of the Gatti-Perka by worm technique will let the Gatti-Perka to molt and go to that part of the Gatti-Perka was I cut it 0.5 millimeter or 1 millimeter.
Yeah. One doctor here is asking about your opinion if he is doing apical patency with K-file 15.
No, I'm not advocating this.
No.
10 file is more than enough. If you want to go, maybe 12, but not 15. Once you go 15, you over enlarge. It will not be that big problem. But remember, if you are going to the 15, 1 millimeter over, it will be 17. As you know, 15 taper 2.
Yeah.
So 1 millimeter will be 17. If you are going 2 millimeter, it will be 19. So the control, especially the control of the seal, will be difficult.
Doctor, in necrotic cases with huge apical lesions, do you use larger files for patency?
No, I will stick to 10K file. Even in necrotic cases, I'm not advising to overenlarge the canal. Once the irrigating needle are reaching 2 to 3 millimeter before working length, that's more than enough.
All right, here another question. Doctor, what do you do when the apex is getting wide in order to avoid any sealer puff?
How wide is it? Some texts saying that if you are reaching 50 taper 2, taper 4, taper 6, whatever size, then it is preferable to obturate the canal with MTA. Other references say if you are reaching 70. For me, when I reach 60, when I reach between 50 to 70, I would obturate the canal with the MTA.
All right. Doctor, another question. In case of weak tugback, what will you do?
Weak tugback?
Yeah, sometimes we can't get the exact shape of the apical.
I do apical gauging. I will depend the apical gauging. Once I get the tugback with the apical gauging, then I will depend it.
All right. So I guess this question you already answered. Someone is asking about the MTA apical plug. When will you use it? I believe you already answered this question.
Yes.
All right. There is one question from Dr. Muhammad Sami. His question is about using alcohol as final irrigation solution.
Yes, very, very, very good question. And it's very safe. And you can get a truly dry canal. But I have a questions. Is it halal or haram to use the alcohol in such cases?
This is a very
I will leave this answer for a Prof. Madarati. He will answer it.
So do you usually use it as your final solution, as your final
Well,
irrigant?
I rarely use it, but you can use it, and it's better to use it.
But will that affect the
No, it will
dentin
not affect.
itself? As I
No.
know that it will cause dryness of the dentin, over dryness of the dentin.
I've never seen such at least for me, I didn't read anything like this. Many
Yeah.
articles, many references advocate and advising to use alcohol as a fine irrigant.
Yeah. Especially after sodium hypochlorite, I believe it will remove all the chlorine particles.
Maybe yes, maybe,
Yeah.
maybe.
All right, this
But
is
remember,
great.
what I do,
Yeah.
I prefer to use my fine irrigant cold normal saline.
Uh-huh.
It will relieve pain and will lessen the pain to the maximum level.
Yeah.
That's why I'm advocating to use normal saline, the cold normal saline, in every procedures. In my room, I have a refrigerator, and I let the normal saline to reach a temperature between 2 to 4 centigrade.
Nice.
Okay.
Actually, I'm doing this after reading your post. You're giving out a lot of information all the time.
Okay, I appreciate it. It is my honor, my
Thank
pleasure.
you so much. So I believe we reached to the end of this great webinar with Dr. Abu Ubaida. It was a very great webinar with a lot of information. I don't know if anyone has more questions. Maybe they can type their questions in the comments, and maybe Dr. Abu Ubaida can go back and answer the questions.
What he is saying that to us, one Dr. Abu Ubaida, please show the rhythm of the speak. We cannot catch too many hard informations. Well, you can read the keynote. This video will be saved, right, Dr. Mustafa?
Yeah.
Okay,
It
you
will.
can read the points, and you can send me on Messenger. I will answer all colleagues. Any point I've missed, I can answer it later on.
Yeah.
Okay.
All right.
I think
Thank
I have to ask. I think we have to ask the dentist now.
Yeah. Sure.
Okay. Okay. I will leave this question for you, my followers and my friends. We talked about the steps that can give us good apical control. Do we need to do apical gauging for all cases? Yes. But there is 3 cases we should do apical gauging. I leave the answer for you. Okay.
Yeah.
Thank you so much, Dr. Mustafa, for presenting this and moderating this amazing
Thank you so much.
online conference
Thank you so
webinar.
much.
It is my
It was
pleasure.
an honor.
My honor. Okay, and we missed Dr. Zahar Aswedan. He was supposed to be our moderator, but unfortunately, the same problem with our mates in Syria. Okay, poor internet connection. Okay.
Inshallah,
Thank you,
on
Prof.
Friday,
Rati.
we will have another webinar with Dr. Wael. I will be also the moderator. So
Excellent.
I hope to see you all with Dr. Wael Said,
Okay.
inshallah, from
At
Egypt.
the end of this webinar, we would like to re-thank the sponsoring company, ZAR company as a platinum sponsor, and Dinjoy's company as golden sponsor, and the Coxo as silver sponsor, and the bronze sponsor, ITIF, and the Ramo company. Thank you so much, and see you in other conference.
Inshallah.
Have a good day.
Thank you so much, Doctor, again.
Assalamu
Take care.
alaikum.
Doctor, please save the video.